Hello, everyone, and welcome to Sarcoma Foundation of America's inaugural education session discussion of pediatric sarcoma. This will be the first introductory session in what will be an ongoing series of education sessions focused on pediatric sarcomas. My name is Christy Arishjan, and I'm the Program Manager for Engagement and Research at SFA, and I'll be serving as your host and moderator for this panel discussion. We thank you for taking the time to join us for this important conversation. Before we begin, I'll briefly go over the format and logistical details of the webinar. Joining me are two panelists who are experts in the care of people with sarcoma from two sarcoma centers here in the United States. Also joining us is a pediatric sarcoma mom whose daughter Gracie was diagnosed with a rare sarcoma in June of 2022. Following an introduction during which Jenny will tell us about her family's experience, our experts will share information to help you understand the overall differences between adult and pediatric sarcomas, what makes a sarcoma pediatric or adult, differences in treatments, and where children with sarcoma should be treated. At any time during today's session, you can submit your questions by entering them in the question and answer field at the bottom of your screen. I will then share your questions with our panelists. Please do not use the chat function to submit your questions. Those questions submitted in the chat box will not be addressed. Please remember our panelists will not be able to answer questions related to your specific medical situation. Information in this webinar is for educational and informational purposes only and is not a substitute for medical advice from your physician or care team. Today's session is being recorded and a link will be distributed to all registrants and posted to SFA's website. Finally, as a reminder, all participants are muted and we encourage you to participate by submitting your questions in the Q&A box at the bottom of your screen. Now I'd like to briefly introduce our panel members. Dr. Reed joined Memorial Sloan Kettering Cancer Center as the inaugural head of the Division of Pediatric Solid Tumors and is chief of the Pediatric Sarcoma Service. Dr. Reed has dedicated his career to cancer care for children, adolescents, and young adults and is known for his work in advancing sarcoma clinical research. His research is focused on mechanisms of therapeutic resistance. He holds leadership roles in multiple collaborative groups, including vice chair of the Bone Tumor Committee for the Children's Oncology Group and the immediate past president of the Connective Tissue Oncology Society. Dr. Janeway is the director of clinical genomics at the Dana-Farber Cancer Institute, a senior physician at Dana-Farber and Boston Children's Cancer Center, and associate professor of pediatrics at Harvard Medical School. She cares for children, adolescents, and young adults with sarcomas. Her research interests include genomics, precision oncology, and bone sarcomas. She is the chair of the Children's Oncology Group Bone Tumor Committee. Jenny is a mom and caregiver of Gracie Sage, who was diagnosed with sarcoma in June of 2022 and currently has no evidence of disease. While Gracie was being treated for her sarcoma, she became concerned about the other children that she met while she was hospitalized and began fundraising with the help of her mom. Together, they have raised thousands for cancer-focused nonprofits and are fierce advocates for pediatric and sarcoma patients. Jenny is president of the board of the Move for Gen Foundation. Thank you all for being a part of this discussion. Jenny, I'm going to hand it off to you to get us started.
Hi, everyone. My name is Jenny Sage, and I'm going to tell you today just about my daughter's diagnosis. In June 2022, Gracie came to me and told me that she found a lump on her chest. And when I went to look at it, I felt it thinking it could be a cyst. It was about the size of a dime. And when I touched it, it was very hard and angular and almost had like a vascular cover to it. I reached out to our pediatrician and took her in to see him. And I think, he wasn't exactly sure what it was either. So he sent us to get an ultrasound, which quickly led to an MRI and was the first time I saw the word sarcoma. We were meeting with a general pediatric surgeon at the time, and I will say throughout our entire journey, they did not think it was sarcoma. We decided after, 3 weeks of time, the tumor started growing pretty rapidly and tripled in size. And we decided to do a biopsy and get it out, regardless. It was during that biopsy, my husband and I got pulled into the room and told that it was highly likely that Gracie had cancer. From there, it was really a long waiting game. We were told she had cancer, but they weren't sure what kind. We were actually told that it was highly likely that it was 2 other types of cancer that then she was, finally diagnosed with. And we ended up going to or talking with 3 different hospitals. When we landed at our final hospital, Gracie was diagnosed with CIC duct-spore sarcoma, which is extremely rare. I think at the time they told us less than 200 people had been diagnosed with that. Gracie, we were lucky. She went back in and got her port placed, and they were able to get the tumor out and get clear margins, which was fantastic because this is a very fast and aggressive growing cancer. She then followed with 12 rounds of chemo. She was treated with doxorubicin and ifosfamide and had 21 infusions, IV infusions. And I'm happy to report that a little over for 2 years and 9 months, cancer free or no evidence of disease. And so, we just pray that that continues. But I will say with this diagnosis, we're definitely one of the lucky ones.
Thanks for sharing that, Jenny. I know your experience was really difficult, and you and Gracie are still every day navigating this. So we really look forward to hearing more about what you've gone through and how you're navigating all of this. Dr. Janeway, I'm going to pass it over to you to introduce us to this process.
Thank you, Christy, for the invitation to join the webinar today. I hope you can see my screen, which I think you can. And thank you, Jenny, for that story. It's not a very, it's a pretty common story actually in sarcoma that you told, and I'm glad your daughter is doing well. I am going to just start us off by talking about sarcoma diagnoses across the age continuum or age divide, depending on how you think about it. And I do have a few slides just to illustrate a couple of points. Christy, I hate to disappoint you, but I'm not going to tell you what a pediatric sarcoma is. I'm going to ask some questions because I'm not sure anybody really knows what a pediatric sarcoma is. Is it I use the word cancer, but you can really apply this to sarcomas. Is a pediatric cancer any cancer in a patient less than 18 years old? I would say no, because you can have, for example, colon cancer in somebody now who's 16. We're seeing that more and more. So the age of the patient doesn't necessarily define what a pediatric cancer is or a pediatric sarcoma. Is it a cancer or sarcoma type that occurs more frequently in patients less than 18 years old? I think that's a reasonable definition of a pediatric sarcoma. Or is it a cancer or sarcoma for which pediatric oncologists have more expertise? I would say the second and third bullet here are sort of related to each other. So if something occurs more often in someone less than 18, it's very likely that a pediatric oncologist has more expertise. But as many of you probably know, many of the sarcomas occur kind of across that age divide between pediatric and adult, which is typically 18 in medicine, just like it is in your house. And so it can be true that that there's equal occurrence of that sarcoma in the pediatric population and the older population. And it can be that both pediatric oncologists and medical oncologists who are sarcoma specialists have equal expertise. So to be honest, we sometimes have trouble ourselves defining what a pediatric sarcoma is. So if you're wondering whether I'm going to answer this question today, I hate to disappoint you, but it is actually kind of hard to say what is. On the other hand, we do have some sarcoma types that are very classically pediatric and very rarely seen in older patients. So I'll talk about that too. Just continuing on that theme, I just wanted to talk about the concept of adolescent young adult, because whenever you're talking about pediatric sarcomas, you have to address this particular topic just to make sure that we're all on the same page. So adolescent young adult really refers to that age range, but it's very, very straightforward. Basically, anyone from about the age of where they enter adolescence, 12, 13, 14, up until about 40 years of age, because the adults who are under age 40 are sort of considered to be young adults. Other people have defined this from age 15 to 29. And there are a couple of important concepts around adolescent young adult cancers. One is that sarcomas are an incredibly common diagnosis in this age range. So it's one of the most common diagnosed cancer types in the adolescent young adult age range. Second is that survival for we call this adolescent young adult. The short term for that is AYA. So cancer-related survival has not improved for most AYA cancers, in spite of the fact that survival for older people with cancer and for younger people with cancer has actually improved for the most part. For those AYA patients, and particularly for AYA sarcomas, survivals has really not changed. And for a cancer type, the sarcoma type that I'm particularly interested in, which is osteosarcoma, I'm showing you on the bottom right a chart of change in survival over time from 2000, which is on the left, to 2014. And you can see basically a straight line. And I can tell you that if you extend that out to 2025, it is still a straight line. Potential reasons for the failure to improve survival in AYA sarcomas these are rare cancers. So just like adult sarcomas, the AYA sarcomas are rare. There's kind of variability in the diseases that we see, the actual diagnoses, but also within a diagnosis, variability in how they behave. Adolescents and young adults face very unique challenges in terms of things like health insurance. They're often transitioning from parental health insurance to their own health insurance, but that health insurance may not be great because they're in an entry-level job, for example. They may be facing other challenges in their lives. This is a time when a lot of things are changing and there's a lot going on. And so those challenges can compound the ability to sort of care for them medically. Historically, the clinical trial system is not set up to really serve this group of patients. And so historically, they've had low clinical trial enrollment. One other thing that people talk about, and I think you alluded to, Christy, is perhaps there's different approaches to treatment depending on whether you're being seen in a pediatric oncology clinic or a medical oncology sarcoma clinic, or if you're older, in sort of a practice in the community. So with that background, I'm going to actually go into talking about sort of how common is sarcoma and what sarcoma types do we see across the age range. So this is data from something called the National Childhood Cancer Registry. And you'll notice that even though it's the National Childhood Cancer Registry, I have data all the way up until age 40. And that's because of this adolescent young adult age range group where there are a sprinkling of childhood cancers in there. And so this effort to collect data on national childhood cancers, childhood cancers nationally by the government includes up to age 40. So if you look at soft tissue sarcoma incidence, meaning rate per million population, starting at less than age 1 and going up to age 40, and soft tissue sarcoma is on the left and bone sarcoma is on the right. Maybe I'll grab my pointer here. Give me 2 seconds. Oh yeah, here it is. I'll just grab my pointer. Here we go. Oop, there we go. Okay, so age 1 is here on the left, age 30 to 40 is over here on the right, and up here is increasing incidence the higher the bar is. You can see that for soft tissue sarcomas, the incidence kind of generally like increases as age increases, okay? So soft tissue sarcomas do become more common as people get older. The bone sarcomas have a different shape to them. So if you very uncommon and very young patients, intermediate kind of incidence in the older age range, but with this very unique peak right at that adolescent age range between the ages of 10 and somewhere around 20, 25. You see this kind of peak of incidence. And we think about what we often describe it. We don't know of a correlation between growth and the bone sarcomas, but it happens to correlate with the time when people are growing the most in terms of their height. But then you have to look a little bit more closely. I think many of you probably know that soft tissue sarcoma is not one thing. It's hundreds of diagnoses. And so if you look specifically at the distribution of what soft tissue sarcomas occur at what ages, it varies over time. So I've kind of put in red. Okay, let me explain what we're looking at first. So again, this is showing data by age. So starting at 0 and here going all the way up to 70. This is using, again, that national registry data. So trying to take a picture of all the people across the country who have cancer or sarcomas. And basically, if you look here, these are not incidence numbers. They're not the total count of patients. What they are is taking all the patients who have sarcoma at that age. What are the different sarcoma types that they have, like by relative proportion? And basically what you can see is that in the younger patients, as I've boxed here in red, the most common are rhabdomyosarcoma and these fibroblastic sarcomas. Those have a lot of different names, but they're sort of spindle cell sarcomas. In the middle here is an entity that has varied a lot in incidence depending on what age, what era you look at, but is Kaposi sarcoma. And then as patients get older, the soft tissue sarcomas that become more common are leiomyosarcoma and liposarcoma, so the L-type sarcomas. And then, of course, across all the age range are these like miscellaneous sarcomas, those rare sarcomas that give us that multitude of diagnoses when you look at sarcoma. If you look at stage of presentation, meaning does somebody have distant metastatic disease, regional spread, or localized disease, that actually is pretty stable depending by age. So the proportion of people who present with just localized disease versus spread to either the region or outside that region is kind of stable across the ages. When we look at bone sarcomas, we see something a little bit different. So if you are looking at bone sarcomas by age, what you see is that the peak that I showed you that happens around that adolescent time is mostly made up of osteosarcoma and Ewing sarcoma. And then the older age ranges, really we see very little Ewing sarcoma, but we do see some osteosarcoma. And in fact, this graph is slightly misleading or maybe incorrect. This second peak, what we call second peak in incidence of osteosarcoma is probably not quite as high as it's shown in this figure. It's probably more around here. But the sarcoma, the bone sarcoma type that really does not occur in younger patients, but does occur in older patients is chondrosarcoma. So as you can see, just to summarize, the soft tissue sarcoma incidence or occurrence kind of increases with age. The bone sarcoma incidence mostly is centered around the time of adolescence, that sort of peak growth. However, if you look at specific sarcoma subtypes, some are much more common in younger patients, like rhabdomyosarcoma and these kind of spindle cell sarcomas like the Entrex sarcomas. And some are more common in adult patients like liposarcoma and leiomyosarcoma, and we almost never see in younger patients. And then for bone sarcomas, osteosarcoma and Ewing sarcoma are most common at that adolescent age peak, and chondrosarcoma happens in older patients. I'm just going to make a few comments on sort of the practical realities of taking care of sarcoma patients across the age continuum. One is that there's close collaboration between pediatric oncologists and medical oncology sarcoma specialists at most larger sarcoma centers, most larger sort of cancer programs that have a sarcoma center. And that's because we have a lot of natural affinity for each other. We do very similar jobs. We take care of similar diseases. We have overlapping expertise. For many of us, that includes things like going to each other's tumor boards when we have something, when we're taking care of a patient where the medical oncologist, medical sarcoma specialist might have more expertise than I do as a pediatric oncologist, and vice versa. We ask each other questions. And actually, one small, minor tidbit that you may not know that is quite interesting is that in most, at least in my center, I'm not going to speak for most centers, but I think it's true at most centers, the medical sarcoma specialists, the adult sarcoma, the sarcoma doctors who take care of adults, actually often take care of often take care of adults who are presenting with a classical childhood cancer. The most classic example I can tell you about is neuroblastoma, which is not a sarcoma at all. But when it occurs in like a 30-year-old who can't be taken care of in a pediatric hospital because they're just too old for us, often is taken care of by a sarcoma specialist. That's how tight this connection often is. And we often refer patients between the programs, and we do that for expertise, like you have more expertise than I do, or a clinical trial is available, or there's an availability of a specialized service in one program and not the other. And I think that's really all I had to prepare prepared remarks. And I think Dr. Reed was going to go after me.
Thank you so much. That was some really great fodder for future conversations. I look forward to talking with you more. Dr. Reed, I'm going to go ahead and share your slides here.
As is typical, perfect setup. And thank you, Jenny, for your story. That was wonderful. Christy, thank you for the invite to talk. And Dr. Janeway, excellent setup. And so I was tasked with this specific phrase and then asked to just go. So differences in the treatment of adult and pediatric sarcomas. I feel very comfortable with this topic in my 17 years since finishing training. It's pretty evenly split between me being a true pediatric oncologist sitting across from parents and children and getting consent from parents on treatment in a pediatric hospital, and working in an adult hospital, a cancer center, and taking care of patients who are over the age of 18, consenting for themselves, often by themselves or with their spouses or children or parents. And at one moment in around 2017, I wrote this article, which was called The Immersive Model, which was a way of building what Dr. Janeway was talking about, adolescent young adult centers. And the way we had built it in the adult center that I previously worked was the immersion was me throwing a pediatric oncologist into the wolves of medical oncology and seeing if I would either sync or collaborate. But AOA oncology has an outside of sarcoma, a little bit of an adversarial aspect with leukemia and which doctors do better. I agree totally with what Dr. Janeway said in that pediatric sarcoma specialists and medical sarcoma specialists get along perfectly well, often work with each other for the betterment of the patient. When it's a younger patient with a cancer, a sarcoma that is more common in older patients, or whether it's an older patient with a cancer more common in the pediatric setting. And so what was striking to me and something I wanted to write about in this paper was the different clinical expectations of a medical oncologist and a pediatric oncologist. And so we were hiring at both institutions at the time, and the justification on paper for the hires were the fodder for this table. So in order to justify hiring a pediatric oncologist at the Children's Hospital, we needed to have 15 new diagnoses. In order to hire a medical oncologist, we needed 400 new diagnoses of cancer in a year. So adult oncologists, medical oncologists are expected to see considerably more patients, 9 patients per week, as opposed to about half a new patient per week for pediatric oncologists. And there's just a lot more new diagnoses. There were 16,000 at the new diagnoses of cancer, not sarcoma, because that would be all the cancer sarcomas in the country. But 16,000 diagnoses of cancer at the Cancer Institute and about 120 at our pediatric center. And that's, again, all cancers that came through. So there's a different speed and rapidity and time that you have with patients on pediatric sarcoma. You have a lot more time, which is great. Get to know the patients a little bit better, see the patients much more often. And there's a certain rapidity to medical oncology that makes it a little bit more complicated. At the time, back in 2017, the outcomes were also considerably different, where pediatric cancers were expected to be cured, 80% 5-year survival, whereas metastatic solid tumors were not expected to be cured on the adult side. So there was also different expectations. And so that's what that table is, and that's just a start. But again, with the next slide, my foray into adult oncology was not during my training, but rather when I finished fellowship and I was interested in seeing some older patients with sarcomas, but my pediatric hospital had a hard cap at 21, not because of the comfort with the cancers, but with the comfort of the other multidisciplinary teams that are important in sarcoma care, like nephrology, kidneys are important, and intensive care units and surgical services and all of those sorts of things. And so with the prodding of an orthopedic oncologist who needed some medical oncology help, and with the question, what is the difference between an 18-year-old and a 26-year-old, I boldly went over to the adult center and said, yeah, I'm happy to take care of patients in their 20s. And so what is the difference in treatment of adult and pediatric sarcomas? Well, pretty quickly, 26-year-old patients liked me, and then 30-some-year-old patients were good, and 40-year-old patients seemed fine because we didn't have a medical oncologist in sarcoma. And then I was taking care of a 68-year-old, and I thought, hey, there is a difference between a 68-year-old and an 18-year-old, even though I can't tell you the difference between an 18 and a 26-year-old. And so one of the main differences in the treatment of adult and pediatric sarcomas is just age. And so with the next slide, and the organ that I think of the most in terms of age is the kidney. And so, for example, Dr. Janeway was talking about osteosarcoma, the most common cancer primarily of bone, which peaks during the adolescent years. And so taking care of osteosarcoma patients, we give 3 drugs, doxorubicin, cisplatin, which is filtered by the kidneys, and high-dose methotrexate. And high-dose methotrexate really pushes the kidneys to its limits. We have to give a lot of fluid beforehand, a lot of fluid afterwards. And it is quite clear to me that when you, with every year that goes by, our kidneys are a little bit weaker than they were before. And so this is a graph that lifted from the internet that shows that kidneys do start aging. And while osteosarcoma spans the years, we don't really have a hard cap on when high-dose methotrexate, a very important medicine for osteosarcoma, is not given. I would say that most sarcoma doctors think around 40 is a cutoff where giving high-dose methotrexate is difficult, if not impossible. And so that is one of the things that would affect, in a rather concrete way, the differences in treatment between adult and pediatric sarcomas. We take for granted sometimes in pediatric oncology just how healthy our hosts, our patients are, just how healthy their bodies are. And we can really push chemotherapy to the point where we're trying to make sure we cure their cancer so that they can live the many decades of life that they should get to live. And when we try to borrow that and just move that up to older ages, it's just very difficult. And so this goes beyond high-dose methotrexate to other medicines like ifosfamide and other medicines that really strain our normal organs, and it is at a cost. So the right side of this graph shows the difference. It's a little bit hard to see, but the solid line is treating with just 2 drugs, which you have to do sometimes when you can't give high-dose methotrexate. And the thick dashed line that's about 10% higher is the outcomes in osteosarcoma when high-dose methotrexate is included. So there are times, not necessarily at the 18 divide of classic child versus adult, but there are times when pediatric regimens are just not well tolerated by adults. And so I wanted to get across a couple themes with my slides. And so one of them is age does sometimes matter in terms of how hard we can push a dose. Next slide. When does that matter? It doesn't always matter, but probably the best described to me sarcoma where dose intensity matters is Ewing sarcoma. So I borrow a picture from one of Dr. Janeway's articles. This was a commentary, but essentially 3 drugs we've been maybe not perfectly imaginative in the field's Ewing sarcoma trials over the years, but there was a 3-drug regimen, VDC, that was compared to a 5-drug regimen, and 5 drugs were better than 3 in localized Ewing sarcoma patients. Technology around 2000 allowed for either higher doses of chemotherapy to be safely delivered or for therapy to be compressed into every 2 weeks instead of every 3 weeks, mainly through growth factors. And these showed improvements in care and improvements in outcome as well. So these bars are the overall survival. So 5 drugs is better than 3, and if you can give the 5 drugs quicker, it's better than giving it slower. But there was not always buy-in, and certainly around the time, about 10 years ago, when these were first being reported, there was quite a divide in the pediatric oncology and medical oncology community in terms of whether or not adults can handle every 2-week chemotherapy. And so this was a study started in 2003, reported in 2011. The next study that in the next slide, again, to just show the outcomes again, this was the outcomes of getting the exact same chemotherapy every 2 weeks versus the exact same chemotherapy every 3 weeks. And so the survival in red was about 8% better than getting it every 3 weeks when it was given compressed. But There was a real and sincere and experience-based, a lot of conversations at national meetings, international meetings about, is every 2 week even feasible in adults in a non-pediatric population? So this was an area not so much like high-dose methotrexate, where you can just see that high-dose methotrexate can't be given to a patient. They just physically can't tolerate it. Their levels are too high. They get dangerous. In this case, it was more of a general impression. And so the subsequent study that was done from 2011, and the next slide would be great, um, uh, was again interval compression. Every single patient got every 2 week chemotherapy, and the prior trial did not have a ton of patients that were adults over the age of 18. But this study had 17 cycles of chemotherapy, even more chemotherapy than the prior study. And in this case, 1 out of every 6 patients, 17% of the patients were over age 18. And in this study, I think definitively shows that adult patients can tolerate the every 2 week chemotherapy, and the outcomes were fantastic. And this is one of the few trials with Ewing sarcoma that had very similar outcomes, essentially the same outcomes for pediatric and adult populations. So again, where chemotherapy intensity matters a lot, Ewing sarcoma localized would be the sarcoma that I would first think of for that. When adult patients are treated the same way as pediatric patients, the outcome is equivalent, and so we kind of were able to treat out age, which is thought to be an adverse prognostic factor on previous trials. So it was able to be done, and I think more and more every 2 week chemotherapy is being considered. Now, not every pediatric patient can tolerate every 2 week chemotherapy. Not every adult patient can. So you still aim for this, but it's not always possible. And then so one idea was organ function in the host health. One idea was chemotherapy intensity. The third idea that I would bring to this webinar is how much is the right amount of chemotherapy. So there are times when we don't know that more is always better. And so with Ewing sarcoma, there's still a quiet but a healthy debate about whether 17 cycles or 14 cycles is the right amount. I'm personally someone who gives most patients 14 cycles of chemotherapy. We can get into the nuances of that, but it's probably beyond this webinar. But most people would argue that the last cycle of chemotherapy is not as important as the first cycle of chemotherapy. And so there are times when stopping chemotherapy early is okay. And so the next thing that I'll get to is the general soft tissue sarcoma. And if you can go to the next slide. And I'll talk about the optimal care for, say, and this is again kind of like Dr. Janeway did. This is more of a question than a specific like hard data-driven recommendation. But synovial sarcoma is something where you could get, and so this is a representative soft tissue sarcoma. This is a sarcoma that its epidemiology kind of overlaps the pediatric and adult side pretty well. It's kind of right in between in those younger patients, but both pediatric oncologists have expertise in this diagnosis, and medical oncologists would see enough of this to have expertise as well. A 23-year-old with a 5.6 centimeter synovial sarcoma seen by a pediatric oncologist, I would be almost certain would get 6 cycles of doxorubicin and ifosfamide. The trials done in the 21st century have always had 6 cycles of doxorubicin and ifosfamide for a synovial sarcoma over 5 centimeters. These are ARST0332 and all the subsequent studies, 1421 and others. On the adult side, and borrowing from our European contingent, localized 5.6 centimeter synovial sarcomas were treated on the study that's cited below that was reported in 2012, where patients were randomized to get either 3 or 5 cycles of chemotherapy. This is the survival for 3 or 5 cycles of chemotherapy with synovial sarcoma, and it looks a lot like the 6 cycles of chemotherapy outcome in pediatrics. And so this is a case where dose intensity is not known as much to matter, and I think reasonable sarcoma oncologists could recommend anywhere between 3 and 6 cycles of chemotherapy for these patients. But this is something where we have pretty active debates about what the right amount of chemotherapy is for a given patient. So, so in summary, there are differences in treatment of adult and pediatric sarcomas. Some of these are based on the host, the patient sitting across from you, and what they can tolerate. Some of these are based on the deeply held convictions of an individual medical oncologist. And I think there are trends on medical oncology and pediatric oncology, and a general trend would be more dose intensity for a pediatric sarcoma oncologist. And there are times when the data supports more, and there are times when the data is a lot less clear that more is better. And so with that, I'll turn it over to the more general part of this webinar.
Thank you so much, Dr. Reed and Dr. Janeway and Jenny. We have a lot of really interesting topics to discuss now. I know I have a lot of questions, and we have a few that have come in already from our participants. I'm going to take the opportunity to ask the first question. Dr. Janeway, you immediately kind of took the bait that I gave you a little bit and address the topic of how difficult it actually is to define the pediatric cancer or pediatric sarcoma population. So this challenge that exists not only in the public, but also in the medical community, even among the sarcoma experts, does this have care implications for patients? Obviously, it's a frequently discussed subject, or well, at least reasonably managed within the sarcoma centers, but what about the patients that are seen at other facilities?
At other, yeah, I think, I mean, the sort of, the care, it can be good and it can be a problem. So I would say sometimes it's a good thing. So for example, if a patient is in a sarcoma facility and or even not, and there is the need to get to a clinical trial, for example, the lack of rigidity around like that's a pediatric sarcoma or that's an adult sarcoma allows us to be flexible around where we decide to provide that care. So that's a positive thing. I think the challenge that we sometimes face is, to be honest, and this is a topic that I plan to talk about more and more whenever I get the chance. It's my new soapbox, so to speak. The challenge that I think we face more than anything nowadays is in the drug development space.
Mm-hmm.
And so, and in clinical trials. So there, just so people know, there are, this is challenging for all sarcomas because they're rare for us to get new drugs to patients. Okay, so that's true across the board, whether it's a pediatric sarcoma or an adult sarcoma. Adding to that is there's a set of kind of policies and laws that are in place in order to help. It's also difficult. Sorry, let me say one more thing. It's also really difficult to get new drugs to children with cancer. They need special things. They need us to reassess the dosing. Is it the right dosing when you're younger? They need us to get liquid formulations of medications because they can't swallow pills. So there are a whole set of laws that really encourage or require almost for drugs to be studied in younger patients. The patients with those adolescent young adults sarcomas fall in between. They're not adults, so they don't like get served by everything that's happening for adults with cancer, and they don't really get served by those special rules and requirements for young people, and they fall a little bit in this gap. So in that sense, kind of being in this in-between state is not so great. So I think that there are positives and negatives to this kind of fuzziness that can exist between, is it a pediatric cancer or is it a grown-up cancer? There are obviously times when it's very clear, like Jenny's child, definitely a pediatric cancer, right? Because it's a very young child. On the other hand, that chick rearranged sarcoma is actually something that is seen much more often as patients get up into the older ages. So Jenny was probably in this scenario of like being in a pediatric center and hopefully knowing that all the expertise was sort of flowing down, not just from pediatric oncology, but also from our colleagues who see some of these patients on what we call the adult side.
That's actually a really good segue for kind of what my next question was. So this is also similar to this problem of access and logistics. It's not uncommon for families navigating a diagnosis, especially with a child that's on the younger side of things, to be making, I mean, this is true of all sarcomas, to be making big life decisions about travel for care and where they should be receiving their care. And we talk so much about going to a sarcoma center and seeing a sarcoma expert. So especially for these younger patients, if there is an accessible children's hospital that may not be affiliated with what we would call a bona fide sarcoma center, is it better for them to get to a sarcoma center despite having access to a children's hospital, or would going to a children's hospital be a suitable alternative, especially given what Dr. Reed said about the number of patients that a pediatric oncologist sees on a given day versus a medical oncologist, the rate of pediatric cancer versus adults? How would you advise a family in that situation?
I'm going to let Dr. Reed answer that question. That's a tough one.
Thank you. Thank you. It's very kind.
I'm not giving you any softballs here.
Let's, I think it's going to be helpful to kind of narrow it down a little bit in terms of the scope of the question. So I think that a newly diagnosed mass, and if we're talking about the surgeon says, I can take that out. I don't care where you are. I think that a sarcoma, like a sarcoma specialist needs to be part of that before that surgeon operates. And that could be a surgeon at a pediatric hospital, that could be a surgeon at a sarcoma center. But those are the kind of things that once surgery happens, you've crossed a lot of you've done a lot, and you could do things wrong that you can't really go back and fix. So I would say that before a big decision happens like that, that's the surgery. That is the number of patients I see that they say the surgeon says they can get it all out. So why do a biopsy? It's like, whoa, okay, you need to see a sarcoma doctor so that we have a little bit better sense of things. You need an MRI. You need a pathologist that's going to give you the accurate diagnosis. And people are scared when they first hear that they might have a sarcoma or any kind of cancer. But really, it's really time to slow down and make sure that all the right people with expertise have time to make the right decisions so that you make the right plan rather than having to play catch up, which is always worse in sarcoma. So I would say that it's not, is it a pediatric hospital or an adult hospital? It's who are you talking to, and are they a sarcoma expert? Is there someone who wakes up and goes to bed thinking about sarcomas or not? And that they exist at big places, they exist at small places. All big places have it, and all big places have the other last line of defense against a rash decision, which is a tumor board where people sit down and talk about all new patients, and the radiation doctors, the pathologists, the radiologists, the surgeons, the medical people like us are all talking before acting. I think all of those things are very important.
That's really helpful. Putting in context that there's a multiplicity of perspectives, and in this particular instance, having the perspective of someone who's uniquely qualified to think about a sarcoma, not just a tumor, is really helpful, I think, for everyone to hear.
If I could just add one
please.
thing to that, and maybe Jenny can comment on this as well, but in general, if there's like an agreed upon treatment plan, a sort of chemotherapy treatment plan, very often our pediatric oncology colleagues who are not sort of at a sarcoma center are very expert at chemotherapy administration and at following chemotherapy administration plans. And I would add to that, it is much more difficult for a child to travel to a center than it is for a fully grown-up adult person, because it involves a whole family unit usually, and it's very disruptive to the family. And I don't know, Jenny obviously has much more understanding of this than I do, having gone through it, but I think there's the ability to travel for something that is ongoing and lasting a long time can be much more difficult.
No, I think you're spot on. I mean, it's so interesting hearing you guys talk about it, doing this before. You know, I'm thinking about the decisions that we made. You're 100% right. We were able to stay local. We almost traveled, but I can't actually imagine going through what we went through with my daughter being away from home. obviously if we felt like that was the best plan of action, we would have done anything. But yeah, I mean, it's a lot for a family, and especially if your child has siblings. But there's a lot to coordinate with school and all the other things. So you're 100% right.
Thank you. That's really important to hear all of your different perspectives, so thank you. I have a question coming in from one of our participants. Do adults with a subtype that is more classically considered a pediatric sarcoma or is more often seen in a pediatric population fare better if they follow a pediatric treatment protocol? I think Dr. Reed, you kind of alluded to this already, but if you want to expand on that, that'd be great.
It would definitely depend on the type. And that is what I was trying to present, is that, so the three examples that I presented, so osteosarcoma, chemo intensity matters and chemo tolerability matters on how healthy organs are. And so we do, and I think the medical oncology community also does push to try to give high dose methotrexate, and it just is harder in the adult population. So I think that the effort is there. It's just we really run against patient physiology, how well their bodies can tolerate these kind of chemotherapies. Ewing sarcoma, I think, has been the most controversial area, and I think the controversy still exists to this day with certain oncologists feeling like it's torture to give people chemo every 2 weeks, and it shouldn't be done. But then a lot of times what happens is a medical oncologist will take care of a patient, really insists on every 2-week chemotherapy because they read the literature or they've talked to another patient or something like that. And it really only takes one patient going through. I had a 55-year-old patient recently who every 2 weeks got it perfectly and sailed through chemotherapy. And it converted a couple medical oncologists to say, oh, I guess it can be done. And once they see that it can be done, I think they start to believe a little bit more and it goes there. But Ewing sarcoma is the case where I think there's pretty concrete evidence that every 2 weeks is better than every 3 weeks, and also that it is safe and tolerable in an over 18-year-old population. So I think that those are the things that's one that's helpful. For synovial sarcoma, I struggle, and two patients can see me with exactly the same age, exactly the same health, exactly the same size tumor, location of tumor. They can have the overlapping MRIs, and one might say, I only want 3 cycles of chemo, and one might say, give me all 6. And if I had to choose one variable that differentiates the 40-year-old with synovial sarcoma who picks 6 cycles over 3 cycles in my clinic, I would say it's whether or not they have a child in elementary school. And I think that there are some people who are very worried about the cancer coming back and will do everything to try to prevent it from coming back. Those people are less worried about long-term toxicity and really more worried about, like, let's do everything now. And there are other patients who are, boy, I didn't really have this on my calendar to get cancer right now. I'd like to get over with as soon as possible. And I really don't want anything that's going to potentially jeopardize my future 20 to 30 years from now. And so I don't know that we'll ever answer the 3 versus 6 cycles of chemotherapy for synovial sarcoma. I do feel comfortable with either for a patient like the one I presented. And so, but that's where I would go. So to me, the answer to the question of what does it matter, it depends on the diagnosis and the evidence that those additional cycles or that additional intensity is the difference between life and death.
You actually sort of segued me into another question that I have. I just lost my train of thought. I'm so sorry. Oh, goodness. Where did it go?
Well, while you're thinking of that, Christy, I would agree with Dr. Reed that I think it really depends on the cancer type. There is a lot of joint decision making in sarcoma where the evidence is not entirely clear. And I think that, importantly, you can make that decision together with your oncologist. And I think the same goes for, if you have a 16-year-old with synovial sarcoma, just because you're 16 doesn't mean you have to follow the sort of traditional pediatric way of doing it.
It came back. Thank you so much. So you were talking, you're talking about how like organ support and how pediatric populations kind of can handle a lot. On the flip side of things, do you consider things like development and how, like, the susceptibility of organs in pediatric populations versus adult populations? And is that a factor if you are seeing a medical oncologist versus a pediatric oncologist?
Yes. Let me just comment that the most common place in treatment decisions where this comes up is around radiation. And so younger patients are much more susceptible to the, older patients are full grown, so they don't have any growth effects from radiation. But if you're young and you're getting radiation to a place that's growing, it can really impact your growth. In addition, one of the side effects of radiation can be a risk of another cancer later on down the road, and that risk sort of increases over time. And so if the younger you are, the sort of more time you have for that risk to accumulate. Okay, it's not everybody, it's a lower risk, but it is something that we need to think about. And so in particular, when we're thinking about radiation, we are less likely to just go ahead and give the radiation than in medical oncology, than if you're an older patient. Of course, we do give it if we have to do that to cure the cancer. That's a really important concept. But there are times when we would try to do anything we could with a surgical approach to sort of avoid the effects of radiation. Because sometimes if we sort of halt growth completely, the effects of radiation could be just as bad as a very significant surgery. So that's one thing. I think for all sarcoma patients, thinking about the late effects of our cancer treatment is really important. Our treatment does have the risk of side effects that can linger beyond the end of the treatment. And we really have to think about that in all of our patients. In general, chemotherapy itself does not significantly alter that development. With the one kind of carve out that we really have to think particularly about in our younger patients is preserving their ability to have their own biologic children. And so those of us who take care of younger patients, adolescents, and young adults spend a lot of time thinking about, is there a way in this particular scenario to preserve the ability for someone to have their own biologic children?
Yeah, those are really important conversations, and certainly that's something that we on the advocate side of things are trying to help patients and families bring that conversation to the table, what long-term goals are, and then certainly for the pediatric patients where it's parents and care partners that are helping to make those decisions, that's not always the thing that comes to mind. First and foremost, it's how to help my child survive. So I appreciate you mentioning that for sure. Okay, we are about at time, so I am going to reshare my screen if I can figure out how to do that. There we go. And I'm going to say with that, we will wrap up our session for today. I'm going to thank each of our panelists for taking the time to be with us and sharing your expertise and experiences. We appreciate all that each of you do for the sarcoma community. As a reminder, today's session was recorded and a link will be posted to SFA's website within the next few days at curesarcoma.org. This now concludes our discussion for this evening. Thank you all for participating, and we look forward to seeing you on our next session. Good evening.